So again, a very good afternoon. I'm very thankful to AIOS for giving me this opportunity. So I'll be presenting three cases, relatively simple cases with straightforward diagnosis and management. Only that the outcome was not very favorable. Despite everything, the outcome was not favorable, and that is why I thought I'll present it here. And if the expert panel can offer some suggestions as to what alternatives we could have had. So my case the first case is an 82-year female patient who complained of diminution of vision in the right eye for 1 month. She was a VIP patient. She was the wife of an ex-politician, and she had come to me after some recommendation. So it was a high-profile case. She was a known hypertensive for 10 years, controlled with medications. There was no cardiac history, no history of fever, and no COVID history. So this is the fundus picture of the right eye. The vision was quite poor, counting finger 2 meters, and all I could make out was a slight dilatation and tortuosity of the retinal vessels and few blot hemorrhages in the macula. Left eye vision was 6/18. So this is the OCT picture of the right eye, which showed massive subretinal fluid and convoluted inner retinal layers, along with outer retinal layers. I made a diagnosis of macular BRVO in this case, and I gave the patient injection. I gave the patient injection eccentrics in the right eye. This is the left eye picture, which was normal. The OCT was also normal. To my dismay, when the patient came after 15 days, there was a large clump of cotton wool spots in the peripapillary area in the macula, and now the blot hemorrhages had appeared throughout the fundus, resembling an ischemic CRVO kind of picture. Though on OCT the edema had disappeared, but the patient was very unhappy because the vision had not improved. At this stage, I did an FFA which showed some blot, some patchy hyperfluorescent spots, as well as leakage from the capillaries. And if you see closely in the inferotemporal arcade, there was this non-perfused vessel. The OCT-A was also not very, indicative of a lot of ischemia because there was little bit of patchy dropouts, but not gross ischemia. And this is the left eye picture, which was absolutely normal. So at this stage, I also did a peripheral blood smear, which was normal. A carotid Doppler was normal. Patient was started on systemic steroids after consultation with physician. And this is the picture after 2 months, when the vision had improved marginally to 6/60. The cotton wool spots had disappeared a little, and the foveal contour was normal, but the vision was not great. Then she went to Delhi and she received 2 more eccentrics injections, but still the vision did not improve. So in differential diagnosis, what could it be? Was it post-fever retinitis? Was it viral retinitis? Ischemic CRVO was most likely picture, considering that the vision was very poor. But why was there no visual recovery after anti-VEGF injection? Was it CRVO, but there was no cherry red spot or macular whitening, and there was no gross macular ischemia on FFA or OCTA? Case 2 was a 65-year male patient, hypertensive on treatment. There was no history of hyperlipidemia. There was no cardiac history. There was no history of diabetes. Vision in the right eye was counting finger 3 meter, and you can see this blood and tender appearance of the fundus with the cotton wool spots and vascular tortuosity. The corresponding OCT, just note how massive the subretinal fluid is in the right eye. And then the diagnosis was obvious. I gave her anti-VEGF injection. But after 2 injections of eccentrics, you can see that in the macular area, a thin fibrin-like, ring-like exudate had accumulated. And because of this, the vision was not very, it was not very favorable. And you can see that the edema had disappeared, the foveal contour was normal, but because of this ring-like deposit of fibrin, the vision was not very good. And this is the left eye. Going on to case 3, 55-year female patient, known hypertensive, history of ischemic heart disease 3 years ago, no history of diabetes. She was, her LDL was increased and she was on lip vas. This is the right eye picture and the right eye fundus on OCT. The left eye, you see blood and thunder appearance of the fundus, some pre-retinal hemorrhage along the inferior temporal quadrant, and if you see closely, there were also sclerosed vessels in the inferior temporal quadrant as well as superior to the disc. And this was the OCT, which showed retinal inflammation, it showed intraretinal fluid cysts, it showed subretinal fluid. But to my dismay, after injection eccentrics, when the patient came after 1 month, there were a lot of these hard exudate clumps which had occurred in the macular area, which had got deposited, which were not there earlier. And because of this, the vision was, it had actually decreased by 1 line. So from 660, it became counting finger 3 meters. And there was also the sclerosis of the vessels, as I could make out inferiorly. But because of these exudates, the vision was very poor. This is the red free picture, and see on the OCT the fluid has disappeared, but the exudates have appeared. So there was an interesting article which I came across in BMC ophthalmology, which said that aggravation of the retinal hard exudates after intravitreal injections for cystoid macular edema was studied, and they had studied cases of DR as well as BRVO, and they said that CME with subretinal fluid is associated with a higher risk of hard exudate progression. And the two important factors that they mentioned was the long duration of CME and the high LDL levels identified as risk factors for higher exudate progression following anti-VEGF treatment. In their cases, acute BRVO cases did better than DR cases. So points for discussion is, we all know that in ischemic CRVO in the first hand picture we don't need to do an FFA, but considering my cases, do you think that FFA is mandatory for all cases of ischemic CRVO? Should OCTA be considered in all cases before giving anti-VEGF? And predictors, if any, of the occurrence of hard exudates following anti-VEGF injection, and what precautions we can take for the same. Thank you so much.